Okay, good morning. And now we are deviating a little bit away from the perioperative period to mainly to the ICU, that is the critically ill patients. So can we predict extubation failure? The International Conference on ICU in intensive care schematically represented the various stages in a mechanically ventilated patients. It started with treatment of acute respiratory failure. When the patient is becoming better, you have the suspicion whether the patient can be weaned. And when the patient can be weanable, you will assess whether the patient can be weaned by various modalities. Then there is spontaneous breathing trials and extubation. And if the extubation fails, reintubation. These are the various stages between the admission and discharge of a patient on a mechanically ventilated patient. So the question is, are we considering weaning and extubation separate process or a single process? In an editorial in 2012 in Respiratory Care, the editors borrowed one of the phrases of William Shakespeare and categorically told that tracheal reintubation is caused by too much of good things we are doing. Why? That is, when you see a patient on ventilator, we do so many things for weaning. That is, we will do spontaneous breathing trial, progressive withdrawal. We would like to find out what are the causes, and so on, because we are more worried about the patient on ventilator and its side effects, like ventilator-associated lung injury, barotrauma, volotrauma, VAP, and also. But regarding extubation, we never consider extubation as a separate process. We consider extubation as not a separate process. Just after a weaning, you just pull out the tube. That is what we consider. So we need to consider extubation. Why we need to consider extubation as a separate process? It increases the mortality by 2.5 to 10 times when compared to a successfully extubated patient, and the mortality rate persists even up to 5 years when the patient has an extubation failure. And in addition, it increases the duration of ICU stay, increases the tracheostomy, and increases the hospital cost. Now, before going to the extubation failure, let me go through some of the terminologies which I came across through the literature. Weaning failure is the inability of a patient to tolerate spontaneous breathing without ventilator assistance. At-risk extubation means the patient is, when you consider the patient, we are suspicious whether the patient can maintain airway patency or oxygenation. For example, a patient with a cardiorespiratory failure, or a patient with hypothermia, or a patient with acid-base disturbances, something like that. Difficult extubation is mainly a mechanical term, where a decanulation of the translaryngeal tube is not possible because of the mechanical issues. That is, surgeon might have taken a stitch over the tube, or a patient might have developed a tracheal stenosis, which prevents the tube to come out, or a cuff dysfunction. So this is called difficult extubation. Coming to extubation failure, it is the inability to tolerate the removal of translaryngeal tube. It can be a tracheostomy tube or an endotracheal tube. And it is generally treated with reintubation and usually occurs 24 to 72 hours after extubation. So, is there any acceptable range or acceptable probability of extubation? there is no acceptable probability. What we have to consider is the patient progress, how the patient progresses. If the patient progresses better or relatively well, you can wait for extubation. If you think that the patient progress on ventilator is not so great, you can think of extubation at the earliest for giving a trial extubation. Coming to the perioperative period, Ramachandran et al. Studied that is independent predictors and outcomes of unanticipated tracheal re-intubation immediately after surgery up to 30 days. And he found that incidence is around 1% in the first 72 hours, and it increases the mortality by 9-fold, and half of the cases occurs in the first 3 days of postoperative period. In another study, they found that the incidence is around 0.5%, and they classified re-intubation into 2 types: early, which occurs in the 6 hours, and late, within 6 to 72 hours. Now, let us go through some of the conditions which are increased at risk in the perioperative period: obesity and obstructive sleep apnea. These patients are more prone for postoperative respiratory obstruction, opioid respiratory depression, difficult extubation, and all. Head and neck surgeries, maxillofacial surgeries, and upper airway surgeries, the tracheal re-intubation rate is up to 11%. Endoscopic airway surgeries, it is around 5%. Obstetrics, that change in physiology can make the airway difficult. Rheumatoid arthritis, the prevalence of laryngeal involvement in rheumatoid arthritis is around 13 to 75%. It can be a deviation of the larynx. It can be due to laryngeal nodules secondary to the rheumatoid arthritis, or it can be due to severe arytenoid joint arthritis leading to severe postoperative respiratory obstruction. Cervical spine surgery, anterior cervical spine surgeries are all associated with increased respiratory incidence of re-intubation. It can occur immediately after extubation, or it can persist even after that 1 to 2 days. Even if you keep the patient on ventilator for a few days, even when the patient is extubated, there is a chance increased incidence of extubation failure. Saji et al. Found out that these are the factors: length of surgery more than 5 hours, surgical exposure more than 3 vertebral level, including either C2, C3, or C4, or blood dose more than 300 ml, are all associated with the increased extubation failure. Coming to the etiology in the perioperative period, we can classify it into early re-intubation and late re-intubation. Most of the causes for early re-intubation is airway obstruction. It can be patient-related, surgery-related, or provider-related. Most of the late re-intubations in perioperative period are due to the comorbidity or type of surgery or a postoperative management. Perioperative re-intubation, ASA closed claim projects and the national audit in the UK, they found that most of the re-intubation in the perioperative period is preventable, and it is secondary to less than appropriate care and or judgment, or incomplete hand of communications, and lack of adequate postoperative monitoring. Coming to the ICU, critical care, the incidence is 2 to 5%, and it is most commonly seen in medical ICU, pediatric ICU, and multidisciplinary ICUs. And these are the patients with increased risk. Age is the main factor which causes the extubation failure, then longer duration, IV sedation. And the point is the anemia. Now more and more we are restrictive transfusion patterns. They said that hemoglobin is 10. Some other study is telling that it is 7.5. But hemoglobin level itself is not a trigger for transfusion. So most of the studies now telling that hemoglobin in 7 is accepted for extubation. blood urea nitrogen, end-stage renal disease, acute renal failure, increased blood urea nitrogen all are independent risk factor for extubation failure in the critically ill patients. And cardiovascular failure is also secondary to leading to respiratory failure, or cardiovascular failure itself is another cause for extubation failure. Coming to the etiology, the extubation we can divide into the etiological factors into two. One is load versus capacity, just like demand supply ratio in cardiacs, and it can be due to pulmonary causes or cardiac causes. Or the second reason is the integrity of the airway. It can be airway secondary to lack of airway patency or lack of airway protection. Coming to the load versus capacity, how will we assess the load versus capacity imbalances secondary to pulmonary or cardiac causes? The first question is whether the weaning parameters or spontaneous breathing trial, can it imply any extubation failure? But it may not be always. The weaning parameters may not indicate extubation success most of the time. That is 40% of patients who succeed weaning parameters may require reintubation. And most of the parameters which we look when the patient is on spontaneous breathing trial is not sensitive enough to detect the extubation failure. So in short, the decision to extubate should not be only based on weaning parameters. Coming to the various respiratory mechanics, vital capacity, minute ventilation, airway occlusion pressure, workup breathing. When you look in the literature, there is conflicting results. Now, more and more studies are coming for airway occlusion pressures and gastric tonometry, but as such, it is more cumbersome and it is not practicable in a routine life. Coming to cardiovascular failure, that is when you put a patient from a mechanical ventilation to a spontaneous ventilation, it increases the right ventricular free load, increases the left ventricular afterload, increases the workup breathing, and it may increase extravascular lung water. So you need to assess clinically these patients to find out whether there is any cardiovascular imbalances. And nowadays, ultrasound is there. You can put the ultrasound probe over the lungs to see whether there is any decrease in aeration pattern of the lungs. That is, when the ultrasound probe is present, when there is a change in the airline pattern to a change to a B-line pattern. If there is an increase in the B-lines compared to before, that means the patient has extravascular lung water. So just keep the probe over the four zones, not on the dependent part. You just see there is a change in the A to B-line pattern in a patient. That means the patient is increased extravascular lung water. Coming to the integrity of the airway, first is airway patency. Most commonly done test is the cuff leaks test. It can be quantitative, where you deflate the cuff and look for the leak, or you just keep the stethoscope over the larynx and find out whether there is leak. But it is not qualitative. Then other one is the quantitative. But most of this test, the positive predictive value is very low. So this is the thing, you deflate the cuff. If there is a leak, you think that the cuff leak test is negative. If there is no leak, that means that the cuff leak test is positive. There are two ways you can do the cuff leak test. You can put the patient in assist control mode with a low rate, deflate the cuff, you measure the initial tidal volume delivered, inspiratory tidal volume, then deflate the cuff, then measure the expiratory tidal volume for the 6 breaths and take the lowest 3 and average and find out the difference. If the difference is more than less than 110 to 130 ml, that means the cuff leak test is positive. Otherwise, you can make it as an index, dividing it by the inspiratory tidal volume. If it is 10 to 15%, that means the cuff leak test is positive. Another method is patient is spontaneously breathing. You put the patient on CPAP of 5 centimeter without pressure support, and you find out here you are not finding not taking the difference between the inspiratory and expiratory. It is the difference between the expiratory tidal volume with the cuff inflated and cuff deflated. And you calculate the delta V, that is change in volume, and if the delta V divided by the inspiratory volume, when the cuff is inflated, if it is more than 21%, that means the cuff lift test is positive. Again, ultrasound, laryngeal ultrasound has a role to find out upper airway obstructions, not the lower airway obstruction. And it is easy to predict postoperative stridor in mechanical ventilated patients with the upper airway ultrasound. And you find out an air column. That is, you can see just like a pleural sliding here in a normal patients, and there is an air column anterior to the endotracheal tube. And this should be done if the cuff is deflated. Keep the patient on positive pressure ventilation for some time. After that, you do this test. And if you find that this air column is there, this is the false true vocal cord. And if there is an air column, that means the patient has some space around the tube. And in this picture, the air column width is narrowed and it is expanded, and that means there is no space between the true vocal cord and the tube. That means the patient may develop a postoperative stridor. Coming to airway protection, when you give the airway protection, you need to find the following factors, that is cuff strength, the pharyngeal muscle competency, secretion volume, and the mental strength. There are a lot of parameters which can measure cuff strength, that is cuff peak flow rate, maximal expiratory pressure, maximal expiratory flow. And simple test is the card test. You just remove the patients from the ventilator, keep a card, index card at 1 to 2 centimeters away from the endotracheal tube, and ask the patient to cough. If the patient can wet the card within 2 to 3 coughs, that means he is less likely to fail extubation. Then other tests that peak flow rate less than 16, another study is less than 35. But the basic thing is that if the patient has a good cough and he can cough on command, that means that he can be safely extubated. Intra-abdominal pressure, if the patient has got an intra-abdominal pressure, and if the monitor, and if the change, that is the intra-abdominal pressure change, is less than 30 centimeters of water, it means that the patient, the failure for extubation is more. Secretion volume, you need to find out whether the patient has got sopious secretions. There are various ways they are finding that. If the patient needs suctioning every 2 hours, or if you are quantifying the secretion, it is more than 2.5 ml per hour, or if the secretion is moderate to copious, that means the patient there is increased chance for extubation failure. And again, you can find out the secretions in flow volume loops, a sawtooth pattern. In flow volume loop, that means that the patient has got secretions, and you can assess the patient how frequently this pattern is coming. Again, this can be a reason for. Coming to GCS, various studies have quoted various GCS level for extubation. Some are telling 6, some are telling 8, some are telling 10. And as a whole, most of the studies, 8 may be less than 8 may be associated with extubation failure. But most of the studies are very much doubtful about the verbal scoring and the eye scoring. So most of the studies, they have further studied, and they found out that if the patient can follow commands, simple commands like swallowing, hand grasping, tongue protrusion, that means the success of extubation is more. Combining both, that means when you combine the cuff peak flow rates and secretions, the sensitivity increases and you can detect more failure. Same pattern, they combined 4 tasks, that cuff peak flow rate, simple task, and the secretions, the failure rate. When the increased number of factors are increasing, the success failure rate also increases. Finally, the muscle weakness, which is the most in the incidence of generalized muscle weakness in the critically ill patient is 25 to 50%. The etiology may be varying. It can be from inflammatory sepsis, prolonged ventilations, prolonged sedative, neuromuscular blockers. So it can precipitate a respiratory muscle weakness as well as diaphragmatic dysfunctions, which can lead on to the expiratory failure. So the treatment is same, the reintubation, and you can use, if there is a stridor, nebulization, if there is an increased lung water, diuretics. Non-invasive ventilation, it is suspicious whether you can, that is early institution or late institution of non-invasive ventilation. There is so much controversies in the literature. In conclusion, extubation failure is associated with poor outcome. Be cautious in patients with increased risk factors. Most of the reintubations in the perioperative period are preventable, and it's most often due to inappropriate care. Load versus capacity mismatch and inability to maintain airway integrity are the major causes, and spontaneous breathing trial and respiratory mechanics may not always predict failure. So if you want to extubate, you will have a stable and cardiac respiratory status, spontaneous breathing trial positive, cuff leak test negative, laryngeal ultrasound, air column present, adequate cuff strength, mild respiratory secretions, ability to follow simple commands, and if there is no muscle weakness, you extubate the patient.